speaker is Dr. Devon Curling. As you may know, he's a consultant oncologist both at Princess Margaret and at Doctors Hospital. You may or may not know he's also a board member of ours now. We decided to bring him on, so he's part of us, and he has no excuse not to come to our meetings now. And so we try to get him to do his talk and increase our knowledge on breast cancer. So without further ado, I'll let Dr. Curling come and speak on breast cancer, and hope you have a lot of questions for him at the end. Dr. Curling.
Okay, so good evening, everybody. I like to make these talks kind of interactive because a lot of times we get up here and talk about a lot of stuff, and there are times when the audience isn't really interested. So what I'm going to try to do is highlight some of the main things that I think are important. One thing that I did tonight was I used a lot of data from research that we've done here locally. So the slides that you're going to see are from actual research projects that were done here at the Princess Margaret Hospital. So multiple people involved. Dr. Leanne Bartholomew did quite a bit of research. Dr. Spencer Delaveau and my wife, Dr. Christine Parker, also did some research. So that being said, I'm going to give you a brief presentation and then I'll open everything up to questions, okay? So the first question that everybody asks is why? Why is there so much cancer here? And more importantly, why do we have such poor outcomes? So why do patients not do well, okay? And the next slide that I'm going to show you is a little bit graphic, but I wanted to sink home. I didn't realize kids would be here, so maybe you should cover your eyes for this, but I want you to understand, and I have some more gruesome ones, but I didn't want to show that. But this is the face of breast cancer in the Bahamas, right? This is what we see. This is the typical patient that walks into PMH clinic to see Dr. Shea or to see myself. And the question that I always ask is why? Why did you watch that grow? Why did you just sit there and leave it? And lots of times it's because people are afraid, they feel something there. You ask them, when did you first feel it? Oh, I felt it 2-3 years ago. You know, and you just kind of sat there and watched it. And it's because there's so much fear that everybody thinks if I get breast cancer, I'm gonna die. But the problem is, if you wait until it gets like this, then there's a good chance that you will, okay? So, what's the solution, right? Well, did he have a mammogram today? It's a very, very simple test, right? It's an easy thing to do. And lots of people get really paranoid about doing a mammogram. Is it a little uncomfortable? Yeah, but is it something that's gonna hurt you and ruin your day? No. So I figured I'd just go through the basic steps of it to show you, and you know, we can have a little bit of fun with it at the same time. So, this is what it's like, okay? You put your breast into a machine. The machine compresses your breast so that you can get a good view. If you look in the bottom here, you can see this is what the actual picture tends to look like, and this is just an example of a spot, okay? So, it's not that hard to do. Why people are so afraid of this, I don't know, okay? So, and I'm just highlighting these things to show you guys the different modalities that are available, all of which are available here. You can do every single one of these tests that I'm mentioning here in the Bahamas, okay? So, there are times when a mammogram might show something that looks a little suspicious, but we can't really tell, it doesn't look like much. And Bahamian women have very dense breasts. And in women with very dense breasts, what do we recommend? We recommend an MRI, okay? And you can get an MRI of your breast right here. And you can see the difference. You can see how clear this is. Same breast, okay? And this little space here where they thought something might have been wrong, so they went ahead, they did the MRI, and lo and behold, there's a spot, all right? So, we find a spot. is not the end of the world, right? This is why we're doing the test. We're doing the test so you can actually pick up something early enough to prevent things from going further so that you can actually live. So, this is just an example of what a spot looks like on an actual mammogram, right? It shows it nice and bright and white. And this is what we do. So, we target your breast, we take a needle, and we stick it into the breast, localizing where that tumor is. And this is just an example showing you that you can locate how the needle is going down and into the nodule itself, and picking out that tumor, right? So, we get our biopsy. And the next slide is just to show you that we also have some machines that do everything in one. So you get a mammogram, there's something that's abnormal, and at that very same time, you get the biopsy, okay? So now you do your biopsy, and lo and behold, the thing comes back positive. So it is a cancer. What do we do next? Well, the next step usually is, depending on the size of that, sometimes we can do chemotherapy up front, sometimes we do surgery up front, but we also need to stage you. And for staging, we want to see if that cancer has spread to anywhere else in your body. Has it gone into your lymph nodes? Has it gone into your lungs, your liver, your brain? So that's where breast cancer likes to go, by the way, right? Lungs, liver, bone, brain, okay? So in years past, we would do a CT scan of your chest and abdomen, and we would do a bone scan. Nowadays, we do a PET scan. And this just shows you what a PET scan looks like. So anything that's dark is evidence that there's cancer there, okay? Except for in the bladder and the brain, because the bladder is where you pee it out. The brain is always very hot and very active. And this is just a fancy kind of colorized version of it. And you can see the advantage of a PET scan is that when you, how bright this lights up lets you know how aggressive the cancer is, okay? So you do your PET scan, and now we tell you what stage you're at. And I bring this slide up just to show you that we consider early stage disease stage 0, 1, and 2, okay? And this data actually comes from a review, from a 10-year review that we did, looking at all patients that came in to Princess Margaret Hospital. I think it was from 2005 to 2015. So it was somewhere around 900 patients. So this represents one of the largest databases of Bahamian information that we've ever had. And one of the issues that we run into is that a lot of people talk about, oh, there's so much breast cancer, there's so much this, but we haven't done the research to actually document it and say, well, this is our own evidence and data. And what do we see? We see about 50% is early stage, and about close to 50% is advanced stage. In the US, the majority of cases, 60-70% of cases, are in the early stage. So once again, I show this slide to show you that one of our issues and one of the reasons why our patients do poorly is because we wait until they get into stage 3 and stage 4. Once you're stage 4 disease, barring very certain specific types of conditions, you have a disease that we cannot cure, okay? Stage 2, stage 1, these people generally live out a normal life once they've gotten their treatment. What you don't hear about in the Bahamas is all the 70 and 80-year-old patients that had breast cancer 30 years ago, right? Because we're closed, we don't want to share it, we don't want to tell anybody, I don't want anybody to know I had cancer, right? But If more of that message got out, then people would realize, hey, I feel something, let me go run and get this checked quickly, because if I get it checked quickly and I get it diagnosed, I'm good, okay? Once you get into stage 3 disease, your risk of recurrence starts to go up. And once you get to stage 4, well, as I said, generally it's incurable. So instead of having a disease where you live out a relatively normal life, you could jump down here, and instead of having the conversation of, well, I need you to change your diet, do exercise, and blah, 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 now I'm telling you about your survival and how much time you may or may not have left, depending on where your disease is spread, okay? So the message that we need to get across is staging, staging, staging. We have to encourage people to get screened early so that they don't make it down here, okay? One of the other things, and this data also comes from that same study, is when we look at the grade. So you will notice that the majority of patients are high grade. High grade cancers tend to be more aggressive. So Bahamian women tend to have a much higher incidence of high grade tumors, okay? And I mention all this because the other things that you'll start hearing about once you get your diagnosis is your hormone receptor status and your HER2/neu status. So, once again, this came out of a study in PMH, more than 800 patients. And I can say we're fortunate, about 75% of patients actually had their hormone receptor status done. What were those results? Well, here we can see, and I'm going to tell you why I'm bringing this up, right? So, ERPR positive, which is hormone receptor positive, we see about 56%. HER2/neu positive only, 7.5. Triple negative disease, meaning your hormone receptors weren't positive and your HER2/neu was not positive, 35%. Okay? This is important because in the US, triple negative disease accounts for about 15%. Why is that significant? Because triple negative disease is a lot more aggressive. Your treatment options are fewer. People die faster. So, we have higher grade, and we have a much higher incidence of triple negative disease, right? This is just looking at the receptor status by age, okay? And if we see those less than 40, we see that the triple negative in patients where it was done. Patients that are less than 40 years old have an extremely high rate of triple negative disease, and that's why you hear about a lot of young women dying, okay? And as we get older, we see hormone receptor positivity goes up, and hormone receptor positive disease is a better disease by the way, you live longer. And you can see that as we age, that our triple negative disease goes down, okay? So 35% versus 15, that's huge. This is just the hormone receptor status with respect to the tumor grade, and you can see, once again, saying the same thing, that if you have a low-grade tumor, meaning you're less aggressive, the less likely you are to be a triple negative disease. When you have high grade, much higher incidence of triple negative disease. Triple negative, bad. High grade, bad. The other thing that you hear a lot about in Bahamian women is BRCA1. So the BRCA1 gene is a gene that predisposes you to breast cancer. Originally found in Ashkenazi Jews. Ashkenazi Jews, the rate is about 10 to 12%. In the initial study that was done in the Bahamas, we found that our rate was about 23%. So extremely high once again. And look at what it does, right? This is BRCA1 positive. When you're less than 40, your incidence of BRCA1 positivity skyrockets. When you get into greater than 60 age, you see it's much lower. Now, once again, this data is all Bahamian, okay? Remember that a lot of our guidelines are based on US data, British data, and so on, which doesn't really apply to us, right? Different population. Now, the other study that we did was we looked at the incidence over a period from 1998 up to 2014. And what we found was our average age is between 52 and 56, but it's been rising, okay? So our average age has been increasing, which is a good thing, because breast cancer should be a disease of the elderly, right? Why this is, we don't know, but we'll have to look into it some more. This is breaking down by age group, and you can see that the biggest age group was in the 40 to 49 year olds, okay? That's huge. Why is that huge? In the US, the average age of a breast cancer patient is about 62. Here, we just showed you it's about 54. Okay, so almost 10 years younger. So in the US, it's a disease of elderly women. In the Bahamas, it's a lot of young people. And when you add up the numbers of people below the age of 40, you're talking about 15% of people below the age of 40. So how does that change our screening guidelines, right? In the US, most places, Europe, US, Canada, have multiple different recommendations depending on the group. But in general, they start to say at about the age of 40. If we do that, we're missing about 15%. Do we need to lower our age for screening? It's something that we need to think about, something that's food for thought, and we really got to start to talk about that, okay? And this is that stat, right? So this is just another way of showing it. What do we see here? Patients under the age of 40 in the US, only 4% of the breast cancer population, right? In the Bahamas, 15%. Number of patients below the age of 50, 22% in the US, 41% here. Wow. Below the age of 60, 47, 64. So in the Bahamas, breast cancer is a disease of young people, okay? And of course, the older I get, the younger 60 gets to me. I don't know how you guys feel about that, right? So, this is, pretty astounding when you think about it. The next question is, well, aren't we just like Black Americans then? And what this graph shows you is that we are not, okay? So, when you look at this, the red is Bahamian women, the green is American, and the blue line, sorry about the color there, the blue line is African American women, okay? And what we see here is, once again, who's got the big chunk below the age of 40? Bahamians. African Americans are slightly more than white American women, but we see here that clearly in Bahamian women, it's still a disease of people under the age of 60. African American women start to overtake us right in the 50 to 59 range, but anything below 50 is us, okay? So it shows us that we do have a different disease, okay? Don't know what happened there. Now, the other thing that we need to talk about in the Bahamas, right, is obesity. And everybody likes the, solid ain't good, okay? Solid is fat. And this issue is also probably near and dear to Dr. Shea and Dr. Chin. They have an initiative trying to address this in school kids. And I just point this out to say, when we look at obesity, so BMI greater than 25 is overweight, okay? Now this is going to be very, very important as I go through this, and you're going to look and be like, whoa, wow, right? And remember, the data that I'm presenting is all Bahamian data, okay? The obesity data came from a 10-year review that, once again, I think included somewhere about 700 to 800 patients. So, look at Bahamian women with breast cancer and where they fall. Okay? 50% obese, 31% overweight. So 82% of our females, of our women with breast cancer, are overweight or obese. Okay? Why is that important? We're going to get into a little bit more of that in a bit. So this is just showing you the actual numbers. So you can see obese, more than 350 patients; overweight, more than 200; normal, slightly over 100; underweight, we don't do that in the Bahamas, right? That don't happen. So the next question is, does it make a difference in younger versus older? So we look at premenopausal women. So we can say premenopausal, usually below the age of 45, 50 or so. And we see the numbers still bear out. Obese, 45%. Overweight, I can't see my numbers right here, but still very high, right? So that's in young women. Well, let's look at postmenopausal women. Still high, 56%. Okay? So obesity is huge. We know that obesity increases the risk of breast cancer in post-menopausal women. There's still data on what it does in premenopausal, right? There's evidence now saying that when you have diabetes and hypermetabolic syndrome and so on, that increases your risk of cancer. What increases your risk of diabetes and hypermetabolic syndrome? Being fat, being obese, right? There is a positive association between obesity and breast cancer mortality, meaning that if you're obese or overweight, your chances of dying from complications are significantly higher. And there's mounting evidence that's showing the association between obesity and recurrence, meaning that if you're obese, you have a higher incidence of recurrence. And there's some reasons for that why too. One of the things that we mentioned before was your hormone receptor status, right? So when you're obese, you have an increased amount of estrogens floating around, which therefore can possibly decrease the effectiveness of some of the anti-hormone therapies. Other things, obesity diagnosis and follow-up associated with decrease in physical health. It's associated with a decrease in mental health amongst people who survive, and it's associated with mental and physical deterioration, right? So the question is that we still have to answer, and that we're probably going to be some great research topics for the future. So remember, this is just kind of the foundation. This laid what we have to look at. So, do obese Bahamian postmenopausal patients have higher rates of recurrence than their non-obese counterparts? Well, we don't know. We're going to have to look at that. And remember that their non-obese counterparts are a very small percentage based on what we just saw, right? Does weight loss in the obese breast cancer patient decrease the risk of recurrence? Does weight loss improve your survivorship? I'm going to probably guess and say yes, because weight loss is going to contribute to you being a more healthy individual overall, right? So, are we the biggest losers? Are we losing out on a huge chance? I think probably one of the things that the Cancer Society can think about as an initiative is a weight loss challenge for the country, for the members. Could we decrease our risk of breast cancer based on that? Okay. So that's a wrap for right now, because as I said, I wanted to just give you guys the Bahamian information so that we can better educate ourselves as to how our breast cancer is different from breast cancer in the US, breast cancer in Canada, breast cancer in the UK. And it also is one of the reasons why very often, frequently, there are times when patients come back from a center in the US and we recommend different things to them, and they're like, no, but my doctor over there said this. And we're like, yeah, but this is a different disease here, and there are things that we have to be more aggressive with that I might not be as aggressive with where I am in the US, okay? So that's a wrap. Hopefully that was informative for you guys. And I'm gonna open up to any questions. I was that good? Man, okay. Yes.
I was diagnosed with breast cancer in 2017, and I tell a lot of ladies, you know, get a mammogram done every year, because that's just something that I got every year, and it wasn't detected right away. But the following year, they saw a mass and did further research with a biopsy, and it came up cancerous. You know, doctors always say do self-examination, but in most cases when women do their examination themselves, they don't find anything for the most part that's unusual. So, you know.
Okay, so first of all, yes, I'm always going to encourage you to do self-examinations because no one's going to know your breast better than you. This year, all of a sudden, there's this big mass there. How did that happen if I was doing my screening all the time? But once again, it gets back to this, right? A lot of our tumors are triple negative, which grow faster, they're more aggressive. A lot of our tumors are high grade, grow faster, more aggressive. So it's, every test is but so good, right? It's the best thing that we have, but nothing is 100%. But you want to make sure that you maximize your opportunity to catch it early, right? And the other thing that you'll hear is, I got my mammograms every year, and man, doc, I just skipped 1 year. And 1 year I skipped, and boom, it was there, and it was all over the place. We have nasty disease here. And so that's going to be where we're going to look into doing more research in terms of trying to identify more risk factors. Okay, so screening guidelines, like I say, most countries start at the age of 40, and until we actually sit down and hammer through this data, I guess that's what we have to say. But if you know you have a family history, then that changes it. That changes when I would say for you to start with a mammogram. Okay? So I fight with insurance companies sometimes because they're like, well, we're not going to cover this mammogram because the guidelines say this. And I have to argue the point. No, the guidelines say this, but this is man and woman, strong family history, bang, 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 and so on, right? So don't let it discourage you in terms of not getting your mammograms. You still need to, you know. I mean, and if you think that women are bad with mammograms, trust me, men are worse at prostate exams, right? So they're 100 times worse. But we have to do it. That first picture that I showed you, and Dr. Shea can tell you these things too, it is a miserable feeling seeing someone who's coming into your office who's 31, 32 years old, 3 kids at home, and has disease in their brain, lungs, and liver, and you got to sit there and tell them, this ain't looking good, right? Prepare your family, prepare yourself, because in 3-4 years you might be here. That's a horrible conversation to have, and it's a conversation that we have far too much. And just as a sidebar, I mean, the thing is, the 4 most common cancers in the Bahamas, and I always tell people this: breast, prostate, colon, cervical. You know what they all have in common? Those are the 4 cancers that we can screen for.